Good morning, everyone. Welcome to Breakfast at UMHealth. My name is Dr. Shireene Vethakkan. I'm an endocrinologist with the Faculty of Medicine, and I'll be the moderator for the first session today. So our first presenter is Dr. Tharsini Sarvanandan. She will be presenting a very unusual cause of severe hypertriglyceridemia. We would like to highlight awareness of this very rare cause. As you all know, endocrinologists deal with the very common and mundane, from diabetes to the very rare, and this is one of those very rare cases that we hope you will enjoy. So Dr. Tharsini graduated from the University of Manchester. She's a member of the endocrine unit, and thereafter she very shortly obtained her MRCP UK. So I'll hand the screen over to Tharsini. You can start, Tharsini.
Good morning, everyone. My name is Tharsini Sarvanandan. Thank you, Prof. Shireene, for the very kind introduction. And today I'm going to take you through a case of hypertriglyceridemia. I've titled it Triglyceride Turmoil because I felt like the patient was very much in a turmoil going through the case, and I'll walk you through how this complex case unraveled before us. So it was initially a very routine referral from one of our medical clinics for hypertriglyceridemia. So she was a 46-year-old lady who we knew had Graves' disease. She had a thyroidectomy for that reason, and she was, at the time of referral, euthyroid clinically as well as biochemically on levothyroxine 100 micrograms a day. She also had a history of immune thrombocytopenic purpura, for which she was on prednisolone 5 milligrams, and that disease was stable as well. So the hypertriglyceridemia was an incidental finding on routine blood tests, and we knew that she had a baseline lipid profile about a year prior to this lipid profile, and there her triglyceride levels were just marginally up at 1.81 millimoles per liter. Her LDL was 2.05, and her total cholesterol was 4.13. This is the lipid profile that she was referred to us with. So you can see that the total cholesterol level was 11.7, the HDL was 0.8, and the triglyceride levels were alarmingly high at 52 millimoles per liter. So we were unable to calculate the LDL levels because usually this is done with a Friedewald equation where the HDL as well as triglyceride levels are subtracted from the total cholesterol, and that number is then divided by 5. As you can see, because the triglyceride levels are extremely high, we were unable to do that in this patient's case. So we took a little bit more history from her. She didn't report any episodes of abdominal pain. She denied any anginal symptoms. There was no personal history of diabetes or ASCVD. Apart from the prescription medication, she was on no supplements, no estrogen-containing oral contraceptives, and she was not on any acne medications bought over the counter like isotretinoin. She had a very standard Malaysian diet. It was not high in fat. It was not any particular keto diet. She only consumed alcohol very occasionally. She didn't report any family history of hypercholesterolemia, but there was a premature ASCVD within the family. Her brother passed away at an early age of 44, secondary to an MI. So on clinical examination, she was lean. Her BMI was 22 kilograms per meter square, and she was not Cushingoid, and she had a waist circumference of 79 centimeters. So this is all very normal readings. She didn't have any xanthelasma, so the pockets that you see around the eyes and the corners of the eyes. She didn't have any xanthomata, so the picture here is illustrating xanthoma striatum palmare, which is the yellowish discoloration of palmar creases due to hypertriglyceridemia. She didn't have any tuberous xanthoma, which are firm subcutaneous nodules that you could see over elbows and knees normally. She didn't have a corneal arcus. We didn't screen particularly for this, but this is lipemia retinalis, where there's creamy discoloration of the retinal vessels as a result of chylomicronemia. She also did not have any hepatosplenomegaly. So essentially a normal clinical examination. So in terms of triglycerides themselves, so triglycerides are the most dense form of calories. It's an important source of energy for us. Hypertriglyceridemia results from increased production, reduced catabolism, or a combination of both. Unfortunately, in Malaysia, hypertriglyceridemia, defined by a triglyceride level of more than 1.7 millimoles per liter in the fasting state, is quite high at 33%. Most commonly, this is a combination of factors such as aging, increased body habitus, and a sedentary lifestyle, which then leads to dysglycemia or insulin resistance. And this then has a knock-on effect causing dyslipidemia. So now this table on the right here illustrates different classes of triglyceridemia. So the normal range is less than 1.7, and then it goes from mild to very severe with an upward increment. And our patient falls within the very severe category at 22, at beyond 22.4 with her triglyceride levels of 52 millimoles per liter. So the question then is, what do we do with our patient? So this is an algorithm as to how to investigate patients with hypertriglyceridemia. We know that she had an abnormal blood test, and as such, we will be going down the left side of this algorithm where we have to screen for secondary causes of dyslipidemia like TSH, urea and electrolytes, liver function tests, fasting blood glucose, and we also screen for other causes through the history. We screened for metabolic causes. So she was not hypothyroid. She was not hyperglycemic. Her HbA1c was 4.9, and her alcohol consumption was only very occasional. She didn't have any drugs apart from the prescription drugs. So no estrogen, thiazides, antiretroviral protease inhibitors, antipsychotics, or isotretinoin. We also screened specifically for nephrotic syndrome, but she didn't have any proteinuria, and she had an absolutely normal renal profile. So this is, now we are back to the investigation algorithm, because essentially we haven't found any secondary causes, any common secondary causes, and a repeat lipid profile remained abnormal. So now we are back down here where we have to initiate treatment for hypertriglyceridemia with fibrates and omega-3 fatty acids was the recommendation. They also suggested possible LPL or ApoC2 abnormalities in view of her triglyceride being more than 11 millimoles per liter. So the initial management, so we admitted her from clinic because of the extremely high triglyceride of 52. We repeated it on admission. It had gone from 52 to 15.5, although she did not have any intervention in that interim period. We started her on fenofibrate, 160, very much according to the guidelines, and also a high-intensity statin, rosuvastatin, at 40 milligrams once a day. Ezetimibe just shows how desperate we were, because we were dealing with such high levels. We wanted to throw everything at it. And we also started on fish oil capsules, which are the omega-3 supplements. During the inpatient stay, which was only about 24 to 48 hours, she received intravenous insulin infusion. Insulin now is a very potent reducer of triglyceride levels because it stimulates the production of lipoprotein lipase, which is a crucial enzyme for hydrolysis of triglycerides. But even with that, you can see the triglyceride levels don't drop tremendously. It goes from 15 to 13 without significant change despite the insulin infusion. So we sent her home with some lifestyle advice. So we got a dietitian to advise on low simple carb, low fat diet of less than 1,400 kilocalories per day, and also advised some physical activity for her. We also started her on pharmacological intervention, such as the rosuvastatin, fenofibrate, the ezetimibe, and the fish oil supplements that we mentioned before.
There is a problem with the internet connection on the presenter's side. There has been a question from Prof. Hafiz as to why there was a marked difference in the triglyceride level, the drop from 52 to 13. So as Tharsini had mentioned, this was without any intervention. So at the time, we assumed that this was due to the change in diet when she was hospitalized. But this is an important point to take note of, that the triglyceride levels in the condition that the patient presents, this particular condition, this underlying etiology, tends to spontaneously fluctuate. So that's good observation, Prof. Hafiz. Since it's taking so much time to reconnect, I'd like to mention here, Tharsini will be also highlighting this, that this was a diagnostic dilemma, and we came up with the diagnosis with the help of the nephrology team. Okay, Tharsini, you're back on board. You can start.
Apologies for that. My internet connection had dropped for a bit. So yeah, I'll just go back. We started her on all of these pharmacological treatment, and we expected to see an improvement in her triglyceride levels. because we knew that fibrates could reduce triglyceride levels by up to 50%, fish oil up to 45%, and high-intensity statin in most cases up to 20%. So we thought with a combination of this, we will see an improvement in her triglyceride levels. So I'll show you what it looked like after we started treatment. So at the utmost left here is when we admitted her for the triglyceride levels of 52. And you can see it dropped without any particular reason. And then it had just yo-yoed through the months following after the initiation of treatment without any rhyme or reason. So we knew that she wasn't quite responding to our standard conventional treatment. So unfortunately, she went on to develop complications. She developed very severe acute abdominal pain and was diagnosed with acute pancreatitis. This was managed supportively without needing an ICU admission, and she recovered well without any long-term complications. There is an increased risk. We know that there's an increased risk of acute pancreatitis with hypertriglyceridemia, and the risk of pancreatitis increases linearly when triglyceride levels are beyond 2 millimoles per liter. So now we've got this patient in front of us who hasn't been responding to our conventional treatment and has now developed complications. So we wanted to investigate this further. And although we knew that she had a normal lipid profile about a year prior, we still went ahead and did genetic screening for her. So she had an entire genetic panel done. Amongst those were the ApoB, the ApoC2, the LDLR, the PCSK9, as well as the GPI-HBB1 genes. And these were all negative. Because of a history of autoimmunity, we also did an autoimmune screening for her. And amongst those that were sent are the TSI, which is raised at 3.81, the anti-TPO also raised at 187. She also had a marginally raised ANA at 1 in 80, a positive SSA, and a slightly low C3. But none of this pointed us into any specific diagnosis. So now we're left with more questions than answers for this patient. So we know that she's a young woman who hadn't responded to standard or conventional treatment, and she has a history of autoimmune diseases, and we had a fluctuating triglyceride levels that we couldn't quite explain. So we know that this is a form of acquired hypertriglyceridemia because she had a normal baseline lipid profile. So then this raised the question if this could be an autoantibody causing the hypertriglyceridemia. So autoimmune causes of hypertriglyceridemia are there, but they are exceedingly rare. Some of the more common antibodies are the anti-LPL antibody, the anti-ApoC2 antibody, the anti-GPI-HBB1 antibody, anti-apolipoprotein AV antibody, and the anti-lipase maturation factor 1 antibody. So once again, these are all very rare conditions. So most of the time, most of us haven't actually dealt with any of these cases. So what we did for this patient, we sought help from experts overseas, lipid experts overseas, and we also did a bit of a literature search. So here's what we found. So in 2017, in the New England Journal of Medicine, you can see here, this is an article about autoantibodies against the GPI-HBB1 and molecule causing hypertriglyceridemia. In 2021, we know that chylomicronemia from GPI-HBB1 antibodies was successfully treated with rituximab. This was a case report. And again, in 2023, in the Journal of Clinical Lipidology, we see that the GPI-HBB1 antibodies are again mentioned. So we looked into it. Obviously, it's not very easy to send off these types of antibodies. And we did a little bit of research and found that there was a lab in Japan that processed these antibodies. I'm not going to try and pronounce this very, very long antibody here, but essentially the GPI-HBB1 antibody serum titers were sent off. And lo and behold, it was extremely high at 4,279. So the normal reference interval was less than 58, and hers was well over 4,000. So this essentially confirmed the diagnosis of GPI-HBB1 autoantibody syndrome. So what exactly is this autoantibody syndrome? So the diagram here on the left illustrates what normal lipolysis is like. So lipoprotein lipase, LPL, the yellow circles, are released from the adipocytes, and these bind to the green molecule, the GPI-HBB1, on the basolateral surface of the endothelial cells. These this structure is then moved across into the capillary lumen, where the LPL now is free to bind with the triglyceride-rich lipoproteins to hydrolyze it and produce free fatty acids, as well as some remnants. In the GPI-HBV1 autoantibody syndrome, unfortunately, the LPL is unable to bind to the GPI-HBV1 molecule because autoantibodies are already bound to it, and they are not able to be transferred across into the capillary lumen, which then results in the accumulation of triglyceride-rich lipoprotein, which translates into hypertriglyceridemia, such as the one that we saw in this patient. So we don't know much about the condition. We know that the exact incidence is not known. We think that this is likely due to the low awareness of the condition, and not many patients are being tested for it. From the existing literature, however, we have seen that it has been successfully treated with immunotherapy, including rituximab, mycophenolate mofetil, as well as steroids. So now coming back to our patient, after delivering the diagnosis of the GPI-HBV1 autoantibody syndrome, we then laid out options for treatment for her. So she had immune thrombocytopenic purpura in the past, and she had been on higher doses of steroids. So she was well aware of them and rightly wanted to avoid long-term usage of steroids if it could be done. So then we offered the second option, which was rituximab. It's an anti-CD20 monoclonal antibody, and in autoimmune diseases, it is thought to disrupt B cell function and also decrease plasma cell production. So she decided that she would try the rituximab and see if it worked. So we decided to go with a low-dose IV rituximab at 200 milligrams once a day. 200 milligrams per infusion. We went with the low dose because new evidence has emerged suggesting that this is enough for the treatment of autoimmune diseases whilst lowering the risk of complications from immunotherapy like rituximab itself. So what happens to our patient? So the line in purple here represents the plasma GPI-HBV1 antibody levels. And you can see the line in green is the plasma triglyceride levels that were yo-yoing before any intervention. The rituximab was started around mid-July time. The arrows in blue indicate when the rituximab was given. So she received 4 doses in total at intervals of between 3 to 4 weeks. And you can see that the antibody levels decreased very nicely after the rituximab had been started. And the triglyceride levels mirror the movement of the antibody levels. And after the 4th dose, her antibody levels came down to normal as well as the plasma triglyceride levels. I'd like to draw your attention to the table at the bottom here. You can see that the antibody levels were dropping from 4,271 to 3,600 and subsequently 21. And at the same time, the functional GPI-HBV1 mass increases from 1 to 5 to 8,000. And also there is an associated rise in the LPL mass from 3 to 5 to 36. This then proves our previous explanation that the triglyceride levels are very much dependent on the LPL mass for hydrolysis of the triglycerides. Triglyceride-rich lipoprotein, I should say. So we know that her triglyceride levels normalized after 4 doses of IV rituximab. We had discontinued both her ezetimibe and fenofibrate, but we reduced her rosuvastatin to 10 milligrams without stopping it entirely. She'd been on regular lipid profile monitoring, and 12 months since her last rituximab infusion, her triglyceride levels remain absolutely normal. So her lipid profile done several weeks ago show a normal total cholesterol level of 3.7 millimoles per liter, a triglyceride level of 1 millimole per liter, LDL of 2.0, and a HDL of 1.24. So now she had an absolutely normal lipid profile. Because we know so little about the trajectory of this disease and if it may recur, and if so, when it may recur, we are monitoring her lipid profile regularly at 3 monthly intervals. This is so that we can pick up if there's any rise in a triglyceride level and reinvestigate at that time for titers of antibodies so that we can avoid complications so serious like pancreatitis or any ASCVD that may recur. So some of the learning points that I took away from this case is that individuals with severe hypertriglyceridemia may be entirely asymptomatic until screened or occurrence of complications like acute pancreatitis. We should always screen these patients for secondary causes. Some of the more common ones are hypothyroidism, hyperglycemia, and nephrotic syndrome. What's important to know is there is lack of response to conventional treatment, and especially in the context of history of autoimmunity, then we need to look into autoimmune conditions further. And finally, immunotherapy has been shown to be effective in GPI-HBV1 autoantibody syndrome, but long-term data is scarce, and that's why we will be following up our patient very, very closely. Before I wrap up, I'd like to acknowledge the contributions of all these consultants who were instrumental in managing this patient's case. So Prof. Dr. Lim Sukun, Prof. Pavai Sitaneshwar, and Prof. Jayakanta Ratnasingam are all familiar names to us in the Faculty of Medicine. And finally, the last name on the list, Prof. Masami Murakami, is a chemical pathologist from Japan who helped us run the antibody titers and finally clinch the diagnosis and manage the patient appropriately and successfully, if I may add. Thank you very much for your time. And once again, apologies for the disruption earlier. I'll be happy to address any questions if you have.
Thank you very much, Tharsini. I think we agree that there was a great presentation, and she deserves a virtual ovation for managing to get through everything despite the interruptions. Well done, Tharsini. So are there any questions? This is a very, very rare and interesting case. So we just wanted to highlight awareness of this in patients who are already known to have autoimmune disease. When all the usual causes are eliminated, this is something we should look out for. And of course, again, another important point is the multidisciplinary nature of the team that was needed to manage this patient. We could not have made the diagnosis without our Prof. Lim's help from the nephrology team. He was the one who saw the patient when the patient was referred for lipid apheresis after she developed her bout of acute pancreatitis, and who pointed us in the direction of the autoantibody screen. If Prof. Lim is here, perhaps he would like to make some comments. There is one question here, Al-Hafiz, when facing an unknown case like this, would you look for an international expert for opinion or read religiously from internet or anything? I guess it all starts with reading religiously from the internet. And I think that is what both our team and Sukun did as well. And then you try to look for example, those people who have done work on this, and get the help of our pathologist, Prof. Pavai, whom I believe is also here, to contact them to, do the blood tests. But you do raise an important point, Hafiz. I believe that we are the last generation of diagnosticians. Like AI is going to take over. It's going to be able to search the internet much better than us. And we'll just be there to hold the hands of the patients. So I won't, since there are no further questions, I will hand the stage over to the ID team and Prof. Sashila to take over. Thanks very much.